So let's crack on. We have a fair few of you here already, but I'm sure more of you will filter through. And thank you so much for joining us this morning. My name is Shuaib. I'm sure I've met a bunch of you in previous webinars or maybe in our previous courses. And we've got Dr. Choi with us, who I'll introduce very shortly. But just before we crack on with our cardiology webinar, I just want to go through a couple of things about our upcoming courses and our upcoming webinar series as well. So for those of you who don't know, BitePACES we run a course in the heart of London. We used to be at Barts, but now we're actually at Guy's Hospital. And we have a 1-day course and a 4-day course. And these are upcoming in September and October. So please do check those out. The QR code at the top right should take you to our website. In case you don't know, it's www.bitepaces.com. And I think what makes our courses really unique is that we only have small group teaching. So there's only 2 of you in a group with a patient, and we have a course instructor at every bedside. So it's really for those of you who want to perfect your examination skills and really get quality time with patients with great signs. We do collect data from our previous candidates about what came up in their exams to help guide our teaching and our courses. So we do feel that the patients we have are ones that you could potentially see in your exam. And we also have a WhatsApp group at the bottom right, which I'm sure a bunch of you are part of. I recognize a lot of your names. So please do join that. And that's where we post information about all of our webinars and courses. So yes, please do join the WhatsApp group. And for those of you who joined the webinar today, we do have a discount code. It'll get you £20 off the course, and that's available for this weekend. I know you guys haven't got your PACES course dates yet, but if you purchase the course and it turns out that your exam date is before the course, we'll of course give you a full refund. But please do book onto the course early because it really allows us to prepare and get patients sorted and everything in place. Great. And here's some feedback I just thought I'd post in case you didn't believe me. But I was just going through a couple of emails, and you can see it on the screen. But one of our attendees said they passed with 100%, and they're actually on the faculty now, funnily enough, which is fantastic. And we have some good reviews on Google and Trustpilot. So please do check those out. And without boring you too much, I know on the WhatsApp group we had a little poll about what you guys want for upcoming webinars, and the top 3 things were cardiology, which Dr. Choi is going to take us through today, clinical consultations, which I know that there's a bit of apprehension around because it's part of the new PACES format, and it wasn't like that back when I sat it all the way in 2019, and neurology, which was the most popular. So I'm going to post details about clinical consultation and neurology webinars in the WhatsApp group probably today. I'm just finalizing details, and we will be having webinars on those for you guys. So yeah, without further ado, Dr. Choi is one of our faculty, and he's a budding cardiologist. So I'm going to hand over to him, and I'm sure he's going to.
Great. Good. So yes, very briefly, theoretical understanding how to perform a cardiovascular exam in a systematically. Want you to be able to interpret physical findings, will create a suitable differential diagnosis, and I want you to be able to formulate, by the end of this lecture, to be able to formulate an appropriate management plan. Let's try and keep this interactive, so please chip in with your thoughts. I'm going to make this quite, there's going to be a lot of pictures and not so many words, so I want you guys to chip in with you guys saying more than I do. For those of you who are maybe less vocal, what you can do, have a piece of paper or have another computer screen beside you so that you can type out what you want, what you think the answers are, what your differential diagnosis is for each case, and also will formulate and also write down your management plan. Okay? Good. So briefly discuss the patient format. We'll formulate the management plan. And this is your PACES format for station 3. What MRCP wants you to be able to do is to be able to perform a cardiovascular examination systematically. Through that, to be able to interpret the physical findings that you have found, create a suitable list of differential diagnosis, or try and keep it down to about 3, maximum 4. Don't go too much because I've made that mistake before. Formulate an appropriate management plan. We'll talk through how you're going to do it. And at the same time, you need to be able to demonstrate to your invigilators that throughout your 10 minutes, you need to be able to treat your patient respectfully in a manner that it maintains their comfort, safety, and dignity. The breakdown of the 10 minutes. John, if I am able to see that, I will answer your question. In the 10 minutes, you need to be able to use the 6 minutes to examine the patient and leave 4 minutes to be questioned from the examiner. The example of your written instruction will be this. This 70-year-old man has chest pain on exertion. So a very brief sort of scenario, and it's very prescriptive. Please examine the cardiovascular system. That's all they're going to give you. All right. So, before we begin, how are you going to approach your patient? Let's drop it in the chat, or if you want to unmute. And how are you going to first approach the thing? So, introduce yourselves. Yep, very good. Very good. Yes, you are going. Yep, greet. Introduction. Perfect. So, before you approach your patient, you need to do a few things. Before touching your patient, there are a few things you need to do. Wash your hands and introduce yourself. Have a look at the bedside overview. Look at their hands. So you move your way up, as in what you do in medical school. Hands, neck, face, check their mouth before you examine their chest. So quite a few things to do before you even go to the chest. And unlike other examinations, apart from inspect, palpate, and auscultate, you don't need to percuss. All right. Last but not least, you check your abdomen and your legs. So I'm going to break down each of these sections and we'll discuss. So before touching the patient, apart from introduction, what else do we need to do? Yep, ask the patient's name. What else do you need to do? Pain, yep. Anything else? Take consent, yes. Confirm name and age, good. Perfect. Treat this station like how you're going to do a ward round, okay? Always make sure before you go into the station that you wash your hands. Wash your hands. If they have sanitizer, use it. If they've got gloves, use the gloves, okay? When I did mine during COVID, you have to wear a mask and an apron. So it depends on what they have for you outside of the station, okay? And like what everyone else, what all of you have mentioned, you need to introduce yourself, okay? Get consent and permission from the patient, clarify their name and their age before getting consent to expose them appropriately, okay? And yes, like what Adazi said, tell them what you explicitly want to do and how you're gonna do it as well, all right? Before you expose the patient. For men, it's quite easy. For women, obviously it can be a little bit more difficult, but always make sure that you ask them, are you happy if they can take off their bra during their examination before you examine them, okay? Good. Bedside examination. So that's the next part. Before you touch the patient, this is arguably one of the most important things to do. What do you want to do standing at the end of the bed? Let's see what's in the chat box. Inspect, look for surroundings. What are we looking at in the surroundings? What are we looking for? Okay, yep, medicines is correct. Sputum pot, good. Might come up more in your respiratory station, but yes, sputum. Yes, scars, bracelets, oxygen, good. What else? So these are the things that I can think about. Obviously, first things first, just look at the patient. Okay, what sex are they? Are they young? Are they middle age? Are they old? And yes, like what Zhao said, are they comfortable? Are they in pain? Are they breathless or are they comfortable? Do they look cyanotic or not? Okay. Any sort of deformities? What sort of deformities do you want to look, what sort of deformities that any of you can think about? Pectus, yes. Anything else? Long arms, yeah, very good. Muscle wasting, perfect. And obviously, look for scars. So, what sort of scars typically come out in a cardiology station? Okay, yep, kyphosis, scoliosis. Yep, a median sternotomy scar. Anything else? What other scars typically come out in a cardio station? Mitral valvotomy, good. Okay, pacemaker scars. Okay, good. Vein harvesting, perfect. Okay, very good. So, listen. What are we going to listen for? Because this has come out in a lot of examinations and yeah, metallic click. If you hear a metallic click, you know is giving you a hint already. It's one of the easiest things to find if you can hear it ticking, and there's not gonna and that's in the absence of a clot in the room as well. Okay. Good. Medications that everybody has found. So look for things like have they left all their medication boxes on the table, their warfarin book, their GTN spray. All right. And obviously, if they've got a hint of an ECG on the table as well, might give you a hint as to what their rhythm is. Perfect. Yes, agree with Shuaib. I think before I did my PACE, I went to a PACES course, and the patient that I had was someone with a metallic heart valve. So that was, you can hear that at the start of your examination. So hearing that kind of settles you down because sometimes you might be a little bit worried as to what you may find on an examination. Good. Right. I'm gonna click on this link as bypass all the
Oh, nightmare
adverts.
journey. If you book with TUI, you could. Let's go through a few types of mechanical heart valves. Heart sound for a metallic mitral valve. So let's hear an example of that. And a click will replace the second heart sound for a metallic aortic valve. And let's hear an example of that. Let's talk about a procedure called a
Cool. We can't hear anything. Okay. Did anyone else hear it? No. Let's try again.
Let's go through a few types of mechanical heart valves. There's something called hemolysis. And this is where that
Can you hear it now?
And a click will replace the second heart sound for a metallic aortic valve. And let's hear an example of that.
Cool. Anybody did not hear the YouTube video when I played it the second time? Are we happy with that? You heard it. Okay, perfect. Pay attention when you listen to a metallic valve, like what the video suggests. If it's a metallic mitral, you'll hear it at S1, okay, your first heart sound. When it's a metallic aortic valve, you'll hear it at the second heart sound. Okay, so what I would do when you're sort of having, just have like half an hour, okay, or even the night before your exam, just plug some, you'll hear it much better when you have headphones on. Plug some headphones on, 30 minutes, get a very good YouTube video of what metallic valves are. How do metallic valves sounds like? What do valves, like aortic stenosis, mitral regurg, and just listen it on loop and just get that sound into your head. That's what I did for my exam, before my exam. Good. All right. So after you inspect the patient, from the end of the bed, you're going to come close to the patient. First thing that we do is look at your hands. So starting with we'll start with the top left and work array around around clockwise. Let's throw in the chat. What do we see? What's the one on the top? Yep, clubbing. What cardiac conditions give you clubbing? Yep, i.e. isomangus. Yep, if anyone's got a congenital heart disease that left to right shunt that's not been fixed. Good. Number two. What's number two? What's that second picture? Not quite. It doesn't look very shiny. I mean, yeah, sweating. Yes, absolutely. Okay, so yeah, they could have had an MI. I hope they don't have an MI in front of you, but if they do, treat it as like you're in A&E. But yeah, no, correct. Yeah, someone has an MI, they might feel clammy, or someone with who's profoundly hypothyroid, they might have clammy hands as well. What's that picture of the hand in the red box? In the red box. Yeah, Marfans, what's the name? What's the name of the not the condition, but name of the sign? Arachnodactyly. Perfect. Yes. Going to the next picture of the thumb. Just to the left. Splinters, yes. Yep, you can see nicotine on the other one. And how about the one on the second row on the far left? Second row, far left. Yep, blue nails, sign of. Yeah, cyanosis. So what sort of cardiac patients would be cyanotic that may, no, yeah, what sort of cardiac conditions may give you cyanosis? Yep, congenital heart disease, right to left shunts, what particular heart disease? Yep, tetralogy. Yep, heart failure. Perfect. Good. Right. Bottom left. Where do you see it? Where do you see these two conditions? Yep, i.e. How do you differentiate between a Janeway and an Osler node? Painful, yes. Which one is painful? Ostlers. Very good. What's the last one on the bottom right? Okay, any advancements on bruises? Yes, injection tracts. What sort of patients will have that sort of injection tracts? Yeah, infective endocarditis in patients with IVDU or IVDUs. Very good. All right, moving up. You want to then be able to check their pulse and their blood pressure. So the character of the pulse, what their rate is, are they regular, are they irregular? And always remember, once you've spent that 30 seconds to do it, lift your arm up and check whether they have a collapsing pulse. All right. Have a feel of their brachial pulse as well, and also ask the examiner what their blood pressure is. Mention to the examiner that you want to do a blood to measure their blood pressure on both arms. Okay, you don't actually have to do a blood pressure during the examination itself. Good. Face and eyes. Right. More pictures, more for you to unpick. Right, so let's start with top left and go clockwise. So top left, patient who has been having shortness of breath, and this is their face. What can you see? Okay, why do you think this is mitral stenosis? Malar flush, yes, very good. Looks very similar to the malar rash you get with SLE. All right, number two, elderly woman who has a who's been treated for a cardiac arrhythmia that has been very difficult to control. She's been put, and now she has this face. Yes, gray rash, amiodarone related. Yes. And why do you think it looks this purple? Why do they have this gray slate on their face? Why? Why do they have that gray slate? What does amiodarone contain? Binds to tissues, but what sort of chemical composition is abundant in amiodarone and gives you that particular color? Iodine, absolutely. But yes, so if you have, because of the high composition of iodide ions in amiodarone, that's why it gives you this gray slate appearance. Very good. Okay. So this it may be a patient with that sort of appearance. You might feel an irregular pulse, indicating they might have atrial fibrillation. Right. Third picture. What do you see? Down syndrome. What cardiac conditions are associated with Down syndrome? VSDs, yep. TOF, less likely. But yes, ASDs, VSDs, with VSDs being the most common. Okay. Right. Bottom right. What do you see? Bottom right, bottom right. Hyperlipidemia, xanthelasma. Yep, very good indication of hyperlipidemia. What sort of patients do you think might have this? You know, thinking about the type of patient that you'll see at the end of the bed. Yeah, familiar hyperlipidemia. Okay, you might see them with a median stenotomy and a saphenous vein graft on the medial portion of their leg, indicating they've got ischemic heart disease. Yep, cabbage. Yep, very good. Right. Next one, left of the xanthelasma picture. Yep, conjunctival pallor. Very good. One to the next picture on the left. Ex-ophthalmos. So what sort of patient? Yeah, Graves. What sort of patient in a cardiology bedside exam would have this? What would you expect? Yeah, AFib. Perfect. So your case might be someone who's coming with palpitations. They might have those clammy hands that you feel. They could either have a regular pulse but tachycardic, or they could have they would have atrial fibrillation. And yes, they might be exhibiting signs of heart failure causing thyrotoxic cardiomyopathy. Very good. Last one, far left at the bottom, Ehlers-Danlos. If this patient comes in with chest pain, what would your differential diagnosis be? And you hear a murmur. Chest pain, this patient comes in with a murmur. Dissection, yep. Prolapse, yep. Very good. Yep. Aortic regurg, that's correct. Okay, yep. Could be a Marfan's case as well. Marfan's doesn't give you that stretchy skin, Mohammed. All right. And yes, of course, your other differential will be a pneumothorax, in that if you don't hear any murmurs. But yes, dissections with an aortic regurg is something that you would be on the top of your list. Good. Really enjoying the interaction so far. Neck. Nothing much to look at the neck apart from in a cardiology station, what you want to focus on is, do they have a pulsatile raised JVP? If they do, that might indicate that they have either heart failure or severe TR. If you can't elicit any JVP, you can't see the JVP, always remember to get permission from the patient to allow you to do a hepatojugular reflex. All right. If you can't see any A waves, it might indicate the patient has atrial fibrillation. Or if they've got raised JVP but it's non-pulsatile, it will be a SVC obstruction. Again, that will come out more in your respiratory station, but just know the difference. Okay. Mouth. Right. So mouth, very important as well, gives you a few more clues. They could either have, as in the top left, very nice teeth, cosmetically done, turkey, very good. Or if in that second picture, if your patient has this, comes in with fever and a murmur, what do you think? Infective endocarditis, absolutely. Yep, very good. Well, doesn't have to be an IV drug user. There are some people who just have poor dentition, and you can get infective endocarditis from just having poor dentition itself. So it's good to look for teeth, look at the teeth, look at the gums. Okay. Right. Third picture at the top. On the right. Yep, they are cyanotic. Yep. And last picture at the bottom. Last picture at the bottom. Yep. Calosis. What do they point towards? What medical condition? Yeah, anemia, particularly iron deficiency anemia. Okay. Would come up in your patients, say, if they are they've got heart failure. Iron deficiency anemia can coexist with heart failure. Okay, so important to look for. Good. Chest. Right. Won't bore you with this. So as you move down, you're going to move down to the chest now, the part where everybody gets excited about. All right. So you examine at the end of the bed. You want to come closer to the patient and have a look at their chest again. Very closely. You don't have to spend too much time. Okay. To your left, median sternotomy scar. The answer is there. What's number 2? What's shown in that second picture? What can you see in that second picture? Yep, pacemaker or ICD. Yep, absolutely. They have a device. What other scar does that patient have as well? Just have a look at the chest. Yeah, patient also has a median sternotomy scar. Very good. Just be careful with pacemakers, because if they have had a pocket infection on the left before the car, you might see a scar on the right. Okay, so pacemaker sites tend to be classically on the left, under your clavicle, under the glenohumeral groove. Okay, because that's where your subclavian vein sits. But if there has been a previous pocket infection, just remember you can also have a pacemaker on the right. So remember to just check. If you're not sure when it comes to palpation, just palpate the top. Okay? Or if they've had complications before, they might have their pacemaker in the abdominal wall as well. All right? Not just the left. Always remember to look under the arm. Okay, particularly if it's a young patient. All right, because what's that third picture on the right? What's that third picture on the right? Top right. Looks like ppm, very close. Do you want to advance on that, Tareem? Or anyone else? You're very close. It is a device, not quite an ILR. It wouldn't be a pacemaker. So this is a subcutaneous ICD. Yes, correct, Mohammed. It is a defib. So this is a subcutaneous ICD. So always remember just to look under the arm, okay? Mid-axillary line, left. Good. I don't need to sort of get you guys to guess, but the one at the bottom left is anyone with a central venous catheter. So you might see in your renal patients, or in your cardiac station, you might see them in patients who need it long-term for antibiotic treatment for endocarditis. What's that one on the bottom right? What do you see? Barrel chest. Any advancements? Pectus excavator. Very good. To answer Zainab's question, difference between pacemaker and ICD. No, so pacemakers and ICDs most of the time will be on the left, okay? Or on the right if they've had infections. The reason why some patients have a subcutaneous ICD, which is found in your left axilla, is if they're younger patients, and also for cosmetic reasons as well. Do I answer that question, Zainab? Brilliant. Rabia, no, what's the one on Boron? What's the one on bottom left? What do you think is bottom left? What do you see? Any advancements? Rabia, bottom left. Yeah, tunnel line. It is a tunnel line. So you see in your renal patients if it's an abdo station, but for cardiology in particular, you need it for, if patients on it long-term for endocarditis treatment. Okay? Good. Palpation. So there's not a lot to palpate. Obviously, if you're concerned if you want to just double check whether your patient does have a pacemaker or not, just have a press at the pacemaker site, okay? Either here, or under the axilla, and see, with pacemaker sites, you just want to make sure that they're not infected, okay? You want to look for apex beat. So left fifth intercostal space is where your apex is. What happens if you can't feel it? If you can't feel the pulse, say the patient is obese, okay? or if they have emphysema, yeah, left lateral. Just with the patient 45 degrees, get the patient to lean to the left, okay? And feel whether their apex is displaced. Obviously, if you can't feel the apex, just feel on the right, just in case they have dextrocardia as well. Right, talking about the next thing that we palpate, heaves and thrills. So, to palpate heaves and thrills, like what the picture suggests, base of your fingers, palpate for thrills, which are palpable murmurs, base of hands to look for heaves, where basically it's your left ventricle doing all of the hard work. All right, so that's the difference. Heave, forceful ventricular contraction, particularly in patients with congestive cardiac failure or LVH and aortic stenosis, or thrill if they have a palpable murmur. There's only a few things that you need to palpate. Everybody gets nervous with auscultation, so oh, sorry. Before we palpate, the other thing that you want to palpate, always palpate your carotid pulse to get a hang as to what their carotid pulse is. All right. When it comes to auscultation, after you've palpate the chest, palpate the pulse, leave your hand there, and use your other hand. This is where dexterity comes into play. Have the diaphragm ready to start auscultating the chest. All right. You want to be able to hear the aortic, the pulmonary, the tricuspid, and the mitral valves. All right. The purpose of having your hand on the carotid pulse is to be able to discern whether they have a systolic or a diastolic murmur. So if you can feel a pulse at S1, that's where the pulse is. So at the start of systole, okay? You can feel that pulse, that's the systolic pulse. Breathing, obviously, when you listen to the chest, get them to, what you need to decide in your head is, do they get louder with inspiration, particularly with right heart disease, right side of valves, or expiration with left side, with the valves on the left side of the heart, so mitral and aortic. Always do your Valsalva maneuvers as well. Can we palpate carotid pulse with the thumb rather than 2 fingers? What is everybody's thoughts about that? Because I find it, because the pulse on your thumb might skew it. Yeah, I would better use 2 fingers. Personally, that works for me. But because, yeah, the pulse on your thumb would sort of not, it's not going to be able to help you to characterize the pulse of the carotid as well. So you might mix both up together. So I would prefer to use the two fingers instead. All right. Valsalva. Check whether your valves, whether any valvular abnormality that you've detected changes with the Valsalva maneuver. Once you're at the apex, turn it to the bell. Okay, from the diaphragm to the bell, you want to see whether if you hear a murmur in the apex, is it a mitral stenosis murmur? The reason for using the bell is because the mitral stenosis murmur is a low flow murmur. If you can't hear it, turn them to their left as well. Once you do that, get the patient to lean forward, breath hold on exhalation, and see whether they have an aortic regurg murmur. Always, when you're auscultating the heart, always remember to auscultate the lungs as well, because you want to see is the patient in cardiac failure, and whether they have crackles in their chest. Have a look at the back at the same time. Do they have any scars? Do they have any sacral edema? All right. Good. Abdomen. What is this? SITs. Good. we go down to the legs, all right? Most commonly, you'll find these leg peripheral conditions with the legs. On your top left, it says it in the graphic, chronic patients with chronic venous insufficiency. What do you see on the top right? What is that? Vein harvesting, very good. So patients with ischemic heart disease, okay, they might come up in your patients who've had a CABG, okay? So they would have a median sternotomy scar, all right? It might come up in your patients with valvular heart disease who also needs concomitant CABG at the same time as well. So just remember that. What's the last one at the bottom? What's that last graphic? Pitting edema. Yep, very good. Patients, if you hear any endocarditis, any valves, and they've got, legs that look like this and a raised JVP, they are in cardiac failure. Good. Briefly talking about investigations. So after your 6 minutes, just take 30 seconds to take a deep breath and think about, okay, what have I found? What are my differentials? Use that 30 seconds before you speak to the examiner. And these are your basic investigations. Should not it be on medial malleolus to check edema? I mean, you can, but I think sometimes some people have very swollen ankles, not just because they have not only because they have heart failure. I tend to prefer to do it on the shin, okay? Tend to prefer to do it on the shin because it gives you a more accurate sign. Cardiac investigations are not exhaustive. So things that you want to do at the end of the bed is, okay, you want to decide, do they need an ABG, bedside observations, and an ECG? Your typical bloods that you do, BNPs, TROPs. If they're in heart failure, make sure you check their UNEs, their iron and TFTs as well. Lipid profile for your ischemic heart disease patients, and obviously imaging. Anyone who comes in with shortness of breath and chest pain automatically gets a chest x-ray by the bare minimum. You have someone with heart failure, ischemic heart disease, any valves that you hear, think about getting a TTE, and then so on. The rest of these other more specialist tests will depend on the patient in front of you. And obviously management. Keep it to conservative, medical, and surgical. Use what you've been taught when you were in medical school, okay? So, in the last sort of 20 minutes, what I will do, we'll try and run the sort of two cases. We'll start with 2 cases. We'll do 3 if we've still got time. All right. So case number 1, 75-year-old man, chest pain. Please perform a cardiovascular examination. All right. Chap looks like this. He's comfortable. Hands and nails, face and neck are all normal, and that's his chest. You've seen nothing so far, okay? You're nervous. You don't know what you're seeing at the moment because you cannot hear anything. And just be very careful. In your paces, they can get a patient with no signs, all right? And that's what I got for my gastro exam when I set for my paces. There's no heaves or thrills, no pitting edema, but all you hear is this. Can you hear this? Can't hear. Can't hear. Oh dear. Hey, share the link here. Yes. Bosh. Right, that's the link. So click on that link, go down to the portion where it says aortic stenosis, and just spend 10 seconds listening to that murmur now. Get it into your head what a severe aortic stenosis sounds like. Okay, I'll just play it to anyone who can actually hear this audio. Haven't got the link. It's in the chat. It's in the chat. Click on the link in the chat. We can hear now. Okay, good. The link is in the chat. Is that better? Perfect. Good. For those who can hear it, are you happy with what you hear? What can you hear? What do you hear? So you hear a murmur, second right intercostal space. Yeah, ejection systolic murmur. Yeah, absolutely. Absolutely. Okay. If it's a severe aortic stenosis, you may even lose the second heart sound. Okay. So it will just be whoop, 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 whoop. You will lose that second heart sound. That's characteristic of a patient with severe aortic stenosis. All right. When you hear a murmur, come up with if you feel that you're happy this is severe aortic stenosis, your differentials would be: is this an age-related calcification? Do they have a bicuspid aortic valve, especially if they are younger? Or have they had rheumatic fever before? All right. It typically radiates to the carotid, so we hear that same murmur in the carotids that may increase your suspicion that this is an ejection systolic murmur from an aortic stenosis. Features of severe AS: slow rising pulse, soft or absent S2, a narrow pulse pressure. So if they've given you a blood pressure, your systolic and diastolic pressures will be very close to each other, and you may even feel a palpable thrill in the second right intercostal space. Good. Observations, very simple. If you're suspecting this patient is severe aortic stenosis, always work them up, get an ECG, get bloods, and get an echocardiogram. All right. If they have severe aortic stenosis and you want to work this patient up, thinking about interventions, always make sure that they have you send the patient around, that you mention that the patient needs to have a coronary angiogram. Why? Why do they need a coronary angiogram? If needs cabbage, absolutely. Okay. What are they might even ask you this in your exam, particularly if they want you to score high points. What are the echo features of severe aortic stenosis? So there are 3. Yep, valve area less than 1. Someone else, another point. Pressure gradient more than 40. Yep, good. One more. Yep. So you've got valve area, pressure gradient, low BP. Yeah, can get low BP. What's the other echocardiographic feature? Yes, okay, yep, patient with heart failure, you do want to get these patients in for an intervention. Okay, the other one that you want to look for severe aortic stenosis is the velocity across the aortic valve. that would be more than 4 centimeters per second. Okay. For aortic stenosis, you want to do medical, surgical, and obviously lifestyle. So for anyone with for medical, you just want to modify all their cardiac risk factors. If they have heart failure, make sure they have guideline-directed medical therapy. The 4 hallmarks, 4 medications for heart failure. Surgical. Why cabbage? May you repeat? Okay, so you want, now that you have identified a patient who has severe aortic stenosis, you want to decide what sort of valve you want to put into, okay? The purpose of doing a coronary angiogram is to look for, has the patient got concomitant coronary artery disease? Because if they do, not only you should fix the valve, you want to do a cabbage to fix that coronary artery that is blocked, okay? Because if the patient still has angina post, say, TAVI, and they do have coronary artery disease, why saw the patient, you know, if they have a surgical valve replacement, say, why saw the patient's chest in half twice, okay? You want, with a TAVI versus surgical, you want to decide based on the Euro score, all right? That's dependent on a lot of factors, including age, their physical status, okay? So say a 65-year-old man who's a cyclist gets, and who's normally fit and well, would get a surgical aortic valve replacement compared to your 80-year-old granny who is, you know, going out to do shopping and feeling breathless. She might get a TAVI instead. All right. Someone has infective and we're thinking of valve replacement, so we still do angio for cabbage. If it, yeah, you would still do at least a coronary angiogram to see whether the arteries, you would still check whether the artery needs a bypass or not. I would do. Obviously, lifestyle, modify their risk factors, yearly surveillance in the valve clinic. Good. Case number 2. All right, we've got 5 minutes. 70-year-old woman, short of breath. Please examine her cardiovascular system. All right. She's comfortable at rest upright. She's got a GTN spray on her table. Cool. What can you hear? What could you hear? You know, this is a patient at the, yep, metallic valve. Which metallic valve? Which valve is metallic? Mitral. Why? Why is it a mitral one? Why is it a mitral 1I? S1, perfect. Yep. This patient at the bed, sitting upright. At the end of the bed, you see that she's got a sternotomy scar. You looked at her legs. She has a saphenous vein graft, and she has that murmur. Listen to that murmur. Is it on the click on the first or click on the second? But good, yes, you've correctly identified it's on the first sound. Okay. She's got raised JVP and her legs look like that. How would you formulate your diagnosis using all these information? Just throw in your thoughts in terms of what's the sort of overall diagnosis. She's coming breathless. So if the patient's sitting upright, yep, severe. I've seen something, MR, yep, complicated by atrial fibrillation, cardiac failure. Yep, very good. The stenotomy and the saphenous vein graft. Yep, okay, so good. So that part. So yes, so you have a patient with a metallic mitral valve, okay? If I wouldn't go with severe MR, but in terms of what you heard in terms of the metallic mitral, okay? If a patient has had, why would this patient have a metallic valve to begin with? Yep, you're right, Zhao. Yep, metallic mitral not working, develop AF and decom heart failure. Yep, that works. But why would this patient have a metallic mitral valve before? You know, she's had metallic mitral, you see a stenotomy scar, you see a saphenous vein graft. Why? Yeah, for stenosis, absolutely. Rheumatic fever, infective endocarditis. For someone with mitral stenosis, if they have concomitant coronary artery disease, you need to do a CABG at the same time. And that's probably what she had before. Did I answer your question, Mohammed? Can you see the correlation there? Very good. And yes, like what everyone else say, I'll be worried about a failing valve. Okay, good. So yes, bedside, same old bedside, you know, bedside exam investigations that we've discussed, chest x-ray to look for pulmonary edema. Think about when it comes to formulating your diagnosis, think about what do you want to do? What's the most important thing to do right now? She has heart, you notice she has heart failure. What do you want to do? Give them the furosemide, you fluid restrict bloods. If you have a failing valve, you're suspecting a failing valve, who are you going to call? Who do you want the patient to be seen by? Yeah, cardiology. Very good. Okay. Any patient with a metallic valve, always check for bruises. Okay, always check for bruises because you need to check what their warfarin levels are. And just, you know, read up about the difference in the warfarin levels for metallic mitral and metallic aortic valves. Okay, good. Last one. I'm not going to give you any other information apart from 50-year-old man with dizziness. This is what you see. Last one. How can you tie this up together? Zainab, what's the INR level for aortic valve replacement? So for metallic aortic valve, you're on the aim between 2.5 to 3. For metallic mitral, it has to be higher because of how close it is to the left atrium. So you do want it above between 3.5. Perfect. Yeah, very good. Everybody's on it. Yes, this is a patient with myotonic dystrophy and heart block. Very good. Facial muscle weakness, pacemaker. Well done, everyone. Good, good. So, in summary, with your 10 minutes, use your 6 minutes to examine the patient. Most important piece of advice that I can give you is before your exam, practice, practice, practice. Keep yourself calm. That's the most important thing during your examination. Keep yourself calm, gives you time to sort of cool down, learn how piece all your information together before you speak to the examiner. Okay? Don't rush. All right? Do not rush. Any questions? No questions? Well, I'll leave you to it then. Thank you very much, everyone. And I'll leave this with Shuaib to take over.
Thanks so much. That was fantastic. Yeah, guys, I mean, that was a fantastic talk. I'm sure you'll all agree. And sending your thanks to Dr. Choi. And if there's any questions that come up in the next few minutes, we'll stick around, just post them in the chat. Whilst you're doing that, again, just to cover our course, not all of you here at the beginning, but we do have the courses coming up in September and October. Please join our WhatsApp group. It's, that we post all of our webinar stuff in there so you can attend more of these fantastic webinars. And for the courses, there'll be an exclusive discount which goes out this week. I'll send this to you in an email. But essentially, it'll give you a discount on the courses if you apply it this weekend. Yeah, any questions at all, just let us know in the chat. If not, you can always find us on the WhatsApp group and you can ask anything on there. Yeah, thanks everyone for tuning in on a Saturday morning as well. I'm sure there's plenty of things you could have been doing.
Shuaib, do I get feedback or will you be sending any feedback?
Yeah, well, we can send the feedback forms around to everyone. So please, yeah, I'll send those around to you all in email. Please do fill them out because it's really useful, for portfolios and things. So yeah, please do fill those out.
Can we listen to the pediatric part of cardiology?
Yeah, I'll leave that one to you. I think you're probably better answering that than me.
I've never owned a pediatric cardiology stethoscope before, so I've never listened with it. But I have one of these cardiology stethoscopes gifted to me, so I'm using that one. It helps me with that. I wouldn't suggest using a pediatric stethoscope at all.
I think the point is, I know people get concerned about really subtle signs, and there was, we were having a few conversations on the WhatsApp group and things, but like, I think the point is in the PACES exam, it has to be fair. And like, if there is going to be a sign, it's not going to be a really subtle, like, grade 1 or grade 2 murmur. It's going to be something that it might not be obvious, but it's going to be something that you should be able to pick up fairly comfortably. And it's just, I think what often happens in my experience is that like candidates get anxious and nervous, and that's why they miss signs. It's not because the signs are subtle.
Agree. Absolutely agree.
Yeah, I think
because ultimately the aim is for you to pass.
Exactly. Yeah, exactly. Cool. Let's wrap up there. But yeah, guys, please do check out the course. We're on bitepaces.com. And if, like I said, if your exam date is before the course, we'll offer you a refund. David said, sorry, I think I saw someone say, I paid for the course, but not receiving any details. So, but yes, don't worry, we'll be sending all the details across, David. We are aware of everyone that's paid, and it's just, we're still a fair few weeks out, but we'll definitely get the information to you. And as I said, any questions you guys have, just drop me a message either on WhatsApp or email. We do have data on what's come up in previous exams, and we use that to guide our teaching. And if you're really interested in knowing what some of that data looks like, just drop me a message. But let's wrap up there. Thanks so much, Dr. Choi. It's a pleasure, and hopefully you guys will get to see him in person on the course.
All right. Well, thank you very much, everyone. Have a good weekend.
Take care. Bye-bye.
Bye-bye.